So I'll go ahead and start. Screening colonoscopy, as you know, reduces the risk of death from colorectal cancer by greater than 50%. And high adenoma detection rates are associated with low interval cancer risk. And what we're looking at generally is ADRs greater than 20%, but likely greater than 30% are needed to achieve this. We also know that incomplete polypectomy is a major cause of interval cancers. Fortunately, nearly all polyps that we see can be resected endoscopically. So the important thing is to do a quality colonoscopy. And I think the current goals include reducing operator dependence and then also move low-level performers to a high-end performance. And the first step toward reducing operator dependence is to identify colonoscopists with low ADRs, and then to perform screening and surveillance colonoscopy without measurement of ADR is really no longer acceptable. And here you can see in this recent study that with an increased rate of adenoma detection associates with a reduced colorectal cancer risk and death. So this is compelling data. An increased ADR was associated with an adjusted hazard ratio for interval colorectal cancer of 0.63 and for cancer death 0.5. So the first thing we have to do, particularly new physicians, is training in lesion recognition skills. And a critical concept of this is that a large fraction of precancerous lesions are subtle, as conveyed in the Paris classification. While we know that pedunculated are mainly in the left colon, sessile are evenly distributed, and then more concerning is in the right colon you have flat and depressed lesions. So a high-level detection in cancer prevention and quality should focus on lesion recognition and then different ways of mucosal exposure. When you start with basic mucosal exposure technique, the ability to see the polyp, the first step is a bowel preparation with split dosing. And remember that entire same-day dosing is as effective. And then you have to focus on a very basic withdrawal technique with a detailed effort to probe and expose proximal sides of the bowels, the folds, and the flexures, wash and clean residual debris, and then obtain adequate distension. And then try to use a withdrawal time of at least 6 to 10 minutes. And for improving this adenoma detection rate, you really need an education program combined with a targeted 8-minute total withdrawal with a timer set to force at least 2 minutes in each colon segment. And if you do this, that will give you the ideal colonoscopy. So just talking about preps, we know that the split dose regimen is ideal, and our group showed in this retrospective review the ADR went from 26% to 31.8%. So split dose preps are very important to get the quality you need. The other is the segmental withdrawal time plus enhanced inspection technique, and this was a nice study looking at 12 gastroenterologists in a community-based study. And you can see that ADR improved from 23.5% to 34.5% with, again, a segmental withdrawal time of 2 minutes and enhanced inspection techniques. So you need both of those to attain this. So when we speak about withdrawal time and ADR, again, as I said, it should be at least 6 to 10 minutes. And that doesn't include biopsy or polypectomy. And then again, you have to have adequate distension, washing and cleaning, looking behind folds, and remember to do segmental inspection. So the takeaways from this part are ADR is the primary measure of quality of mucosal inspection. Training should focus on endoscopic appearance of adenomas and serrated lesions. should utilize the Paris classification for describing lesion morphology. Split dose or same-day preps are essential, utilizing sound basic inspection techniques, and then a withdrawal time is a secondary measure, not a primary measure. Now, there are also adjuncts that we can use to look at the mucosa better, and I'll first discuss non-device measures. And you can see here ADR metrics, report cards, public reporting, a second right colon examination, patient rotation, and water exchange. So this was a study called the EQUIP trial that looked at 15 endoscopists with education. And as you can see, there was also, they looked at techniques to improve detection, techniques to distinguish adenoma from hyperplastic, videos. They had monthly feedback, and the results were reported. And you can see in those that were trained, the ADR improved from 36 to 47%, whereas in those that were not trained, there was no improvement. In addition, you can look at performance report cards and the impact of feedback on ADR. And in this study that was done, you can see that the overall ADR for the group improved from 30 to 37%, and low detectors improved the most. So again, report cards can be very effective. Another important one is the double right colon examination, where you look at the colon, at least in the right colon, twice. You can do it either with a forward view or retroflexed. And this study showed that no matter which way you did it, a second right colon evaluation was much more effective, and the ADR and at least one additional adenoma was detected on the second withdrawal. And a second exam of the right colon should be strongly considered in patients who had adenomas discovered in the right colon. And again, you can do it forward or in a retroflexed view. What about water exchange? That's been studied in this recent publication this year. With water exchange, overall ADR was 18.3% with water exchange and 13.4% with routine. And this increase was observed in all categories. So it's recommended that colonoscopists, particularly with a low ADR, should consider using water exchange for performance improvement. So the takeaways here are that measuring and reporting ADR may improve polyp detection. A double right colon examination is very important. Distension is important for polyp detection, and water exchange also can improve ADR. Now we'll move to devices. And so there are several devices now available to do that, and you can classify them as mucosal exposure tools or tools for highlighting flat lesions. And so we'll go through these, and then we'll go through those. So the panoramic third eye cap, it originated as the third eye retroscope. And this new model is easier to use and clips onto the exterior of the colonoscope, and therefore the working channel is free. I will say with this new device, clinical trials are lacking, although the original third eye retroscope did show increased ADR. And here you can see what it looks like as you're withdrawing, and so you get views, the forward view, and then you also have lateral views, and you can see here a polyp was detected there behind a fold. And this is somewhat similar to FUSE, the full spectrum endoscopy, which is a wide angle colonoscopy. There are 3 cameras and 3 screens again, and a tandem study produced a reduction in adenoma miss rates from 41% compared to 7%. The main concern with this technology at this point is lower image resolution. Others have looked at cap-assisted colonoscopy, and in this meta-analysis, you can see that the adenoma detection was no different. There was a reduction in cecal intubation time with cap-assisted colonoscopy by 40 seconds, but at least you can see here it didn't show a difference in adenoma detection. Now that's different than this most recent study in GIE, which looked at, it was a systematic review and meta-analysis, and they did find that with cap-assisted colonoscopy, proximal adenomas were higher, and there was an improved detection rate of flat adenomas. So I think that remains to be seen, but a lot of endoscopists like using the cap. There's also the GI endoscope and balloon platform, and there was an initial study which showed an adenoma detection rate quite high at 44.7%. And in this tandem study that was more recent, 126 patients, the adenoma risk rate in the GI group was significantly lower, and detection of additional adenomas was higher, particularly in the right colon group. And it uses this balloon, and here you can see the basic concept is to get to the cecum, and then you inflate this balloon, and as you pull back, it flattens the folds, and you can get a better look at the colon for polyps. There are other devices that do the same. This is the EndoAid, and you can see that in 66 patients, there was an improvement with the endo rings, 10% adenoma miss rate compared to 48%, and also an improvement in the secondary outcome, which was the ADR. And this, again, attaches onto the tip of the colonoscope, very easy and safe to use. And again, as you can advance with this, and then as you pull back, it flattens the folds. Same concept with the endocuff, which works the same way, and again showed an improvement in ADR using it compared to conventional colonoscopy. And it works again the same way and easy to use. And again, by going into the colon and then withdrawing, you can flatten those folds. This was a recent study that looked at the third eye retroscope versus fuse versus endo rings. And the conclusion was that there was an increased detection with adenomas that were less than 10 millimeters compared to standard colonoscopy using the third eye retroscope and fuse. And so the question is, which technology for the future is going to be better? But clearly, these devices that look behind folds are better than standard colonoscopy. So takeaways from this are that the data are mixed with regard to efficacy of the wide-angle instruments, because the studies are not so good, but the devices that are fixed to the colonoscope that flatten the folds are clearly effective in increasing ADR. So if you're going to do one thing, it would be to take the endo ring or the endocuff and add it to the colonoscope. What about high definition versus standard definition? This was a meta-analysis, and again, there were 5 studies, and there was significantly more polyps that can be detected, but with regard to advanced adenomas, there was no detection of there was no difference in the detection of advanced adenomas. But we know that high definition otherwise will help you there. This was a look at NBI versus high definition white light, no difference in adenoma detection. So it's not clear that electronic chromoendoscopy is of any greater benefit in terms of detecting more polyps. Same thing with FICE, limited number of studies, but when compared to white light or NBI, no significant benefit. And when compared to targeted indigo carmine, the mean number of adenomas were similar in both groups. So again, electronic color enhancement may not be a benefit. This study suggests, though, that pancolonic chromoendoscopy can be helpful because it markedly enhanced the adenoma detection in an average risk population and is practical enough for routine use. So the takeaways here are that high definition does improve ADR by 2 to 4%. Chromoendoscopy is effective for increasing ADR. Electronic chromoendoscopy has been generally ineffective. Second generation technologies, which I didn't talk about, like blue laser imaging, wide field fluorescence, may be effective, but the studies are lacking. And computer-aided diagnosis of colorectal polyps during colonoscopy is still under development and what we call deep learning techniques. So in summary, ADR is a valid quality measure and can be clearly improved. Becoming comfortable with benchmarking and comparing yourself to others is very important. Complete colonoscopy is critical. Split dose prep improves quality and tolerance. And then more importantly, good technique is essential. We have to slow down, we have to inspect the segments carefully, look behind folds, remember segmental and timed withdrawal of at least 2 minutes in each segment, examine the right colon twice, look for flat lesions. Studies have shown that 4 eyes on the screen are better than 2, so if you have nurses and technicians in the room, it's good if they're looking too. Remember that technology can help, but is no substitute for expert technique. And high definition and chromoendoscopy can increase ADR. Thank you.
Muchas gracias, doctor Leighton. Les invito a los ponentes a acompañarnos.